Good evening and thank you everyone for joining us today. I, Amit Saxena, along with my colleague, Dr. Deepika Chawla from Medical Services and Mr. S. Ramkumar, Zonal Manager, Jagsonpal Pharmaceuticals, are pleased to welcome you all to this scientific webinar to interact with our experts on the topic of Inositol in PCOS. This is knowledge sharing initiative of NAARI division of Jagsonpal Pharmaceuticals, the makers of Cystelia-M, chewable tablets, and Cystelia-35. Our expert commentator today for the session is Dr. Mala Srivastava. Dr. Mala Srivastava, madam, is Head of Gynae Oncology Unit, Senior Consultant and Professor GRIPMER, Gynae Endoscopic and Robotic Surgeon at Sir Gangaram Hospital, Delhi. She is Vice President-elect ISOPARB and past President AOGD. Welcome, ma'am, and I request you to please kindly initiate.
So it's my pleasure to introduce the speaker of the evening. Today evening, we have the pleasure of getting to know about PCOS, which is the burning topic of the day, from none other than Dr. Kavita Agarwal. We all know Dr. Kavita. Dr. Kavita Agarwal is a honorary professor, Indian Menopause Association, and she is also at Safdarjung Hospital and VMMC Hospital, member Family Welfare Committee of FOGSI, IMA-CGP Assistant Secretary, past Vice President IMA South Delhi, Chairperson Infertility Subcommittee of AOGD, National Corresponding Editor of Jogi, Organizing Joint Secretary of FOGSI Bad Obstetric History Conference, Training in Infertility from Rainbow IVF Agra, Training in Fertility from Asstt, and she has more than 50 publications, and she is a very eager teacher. We all know as a great academician and great person. Over to you, Dr. Kavita, for your scientific deliberation. We all are waiting to hear from you.
Thank you, ma'am, for your kind words. So good evening, everyone. I'll be talking on PCOS and inositols. So first, I'll be just giving a brief introduction to PCOS, then the role of insulin in PCOS, the basic science of inositols, the clinical trials, the efficacy and the safety of inositols, which have been proven by the clinical trials, and then finally the treatment considerations or what the guidelines have to say, what are the recommendations. So starting about PCOS, if we see in 1990, we had National Institute of Health criteria, which used to say that when we define PCOS, we should have hyperandrogenism and oligoamenorrhea or amenorrhea. Now, in 2003, we came with Rotterdam criteria, which said any two. It can be hyperandrogenism with polycystic ovaries, oligomenorrhea with polycystic ovaries, or hyperandrogenism with oligomenorrhea. So now we have two more phenotypes. That is, with polycystic ovaries, it can be only hyperandrogenism or only oligomenorrhea. Then in 2006, we had Androgen Axis Society, which said hyperandrogenism is a must. So if we see what we are following is the Rotterdam's criteria. which says that there should be 2 more new phenotypes. In 1990, when NIH gave oligomenorrhea and hyperandrogenemia, so there could be only 2 phenotypes, that either the patient have all the 3, that is ovulatory dysfunction, hyperandrogenemia and polycystic ovaries, or has both hyperandrogenemia and ovulatory dysfunction. A and B were the only 2 phenotypes which were included. But now we have, with Rotterdam criteria, C and D phenotypes, which are the milder phenotypes. In that, there can be polycystic ovaries with ovulatory dysfunction, that is phenotype C, or polycystic ovaries with only hyperandrogenemia, that is phenotype D. So identify the 2 milder phenotypes has been done by Rotterdam, and we all are following Rotterdam criteria. So women with polycystic ovaries, clinical or biochemical hyperandrogenism, and normal ovulation, that can be also a 1 phenotype, which is a mild type again. So in this, you will be having slightly increased body weight, mild hyperinsulinemia, mild insulin resistance, mild dyslipidemia. So when you don't have all the 3 categories with you, in fact, basically when you're having 2 mandatory, and out of these 2, 1 is polycystic ovaries, so it becomes a mild phenotype of PCOS. When you have both ovulatory dysfunction and hyperandrogenism, then it is a classical. So if we see, according to the body weight, there has been a study which showed the distribution of body weight in classic and the ovulatory PCOS. Here we say with classic, that is the anovulatory one. In this ovulatory, the ovulation is occurring, that is only polycystic ovaries and hyperandrogenism. So if we see here, the obesity and overweight are more in the classic PCOS. As I said, ovulatory PCOS, in which the ovulation function is normal, but we are putting it under the PCOS category by the Rotterdam criteria because she has polycystic ovaries with hyperandrogenism. So she is a mild category. So she will have everything, all the symptoms, all the signs in the mild form. And this, if she has anovulation in PCOS, it comes in group 2. That is WHO class group 2, which is not estrogen deficient. It has low FSH, high LH levels, oligomenoric or anovulatory cycles, and this amenorrhea responds to progesterone challenge. It is a most common type of problem and includes PCOS patients, and it responds to insulin sensitizers, which I'm going to talk about today. And also for ovulation induction, you can give clomiphene, letrozole, drugs used for ovulation induction. So coming to now, what I'm talking, that is irregular cycles and ovulatory dysfunction. So what does that actually mean? So when the patient comes to you in the OPD and says irregular cycles, what does that actually mean? It can be just that she has attained menarche and she has come with it. So mind you, that is perfectly normal. So Eshrey says irregular menstrual cycles are defined as more than 1 year to less than 3 years post-menarche when it is less than 21 or more than 45 days. Greater than 3 years post-menarche to perimenopause, less than 21 or more than 35 days, or less than 8 cycles per year. So if it is less than 3 years, in the first year of menarche, achieving menarche, first year post-menarche, nothing to be done, that is normal. 1 to 3 years, you are taking the upper limit as 45 days. When it becomes more than 3 years post-menarche, the limit has come to 35 days. And now if it is just greater than 1 year post-menarche, there is one condition: if it is greater than 90 days, that is greater than 3 months for any one cycle, or primary amenorrhea by the age of 15 or greater than 3 years post-thelarche. If these conditions are there, then only you will call as irregular cycles or ovulatory dysfunction. Now, the second thing what we say is clinical hyperandrogenism. Now, the patient mostly comes to our OPD with irregular cycles. So now we know when to evaluate such patients, when to put them into the Rotterdam's criteria. Second, what the patient can come is with hyperandrogenism features, that is acne, alopecia, hirsutism. Now, for these also, we have certain scorings. For hirsutism, we have Ferryman-Gallwey scoring with a level of more than 4 to 6. And similarly, for alopecia, you have this Ludwig scoring. Now coming to the third thing, when you are suspecting PCOS, but the patient has only one thing, that is maybe just irregular cycles. So you want to know about biochemical hyperandrogenism. So calculate free testosterone, free androgen index, or calculate the bioavailable testosterone. This will help you to define whether the patient has biochemical hyperandrogenism or not. Now, if supposing the patient has just irregular cycles, no feature of hyperandrogenism, but if you have a suspect she has PCOS, then you go for ultrasound. So ultrasound again should not be used for a diagnosis of PCOS in those women who have less than 8 years after menarche. So within the first year for irregular cycles, we are not evaluating the patients. Similarly, for less than 8 years, we are not doing ultrasound. For polycystic ovarian morphology, it has to be done only more than 8 years post-menarche. So this criteria comes after 8 years of menarche. Excuse me. The threshold is a follicle number per ovary of greater than or equal to 20. And we are excluding the large dominant follicles or corpus luteal cyst, or an ovarian volume of greater than or equal to 10 ml. Then only we say polycystic ovarian morphology. And finally, with the Rotterdam criteria, you can make the diagnosis of PCOS. Now moving on, when you have made the diagnosis, moving on to the what all you need to investigate. See, PCOS is a complex condition. It is a challenge for the clinician. However, after making the diagnosis also, there are certain features which are attached to it before you go on for the treatment. That is, it's a heterogeneous disorder with a wide spectrum of signs and symptoms. There can be oligomenorrhea leading to infertility, hyperinsulinemia, the associated comorbidities, that is type 2 diabetes, gestational diabetes, metabolic syndrome, cardiovascular diseases, and can even lead to, in the later stages, atherosclerosis, hypertension, endometrial cancer. So we have to be open to all these things, that these things are not, our patient is not having all these comorbidities along with PCOS. Because we have to treat the patient as a whole. It's not that we just treat her hyperandrogenism or her ovulatory dysfunction or just diabetes. We have to screen the patient for everything, and that too with the increasing age. The studies have proved that there is increased risk of diabetes and MI, as well as its PCOS is present in 42% of cardiovascular disease patients. So we have to be alert about that also. Now, when we know our patient diagnosis as well as the associated comorbidities, that if she is having infertility, diabetes, hypertension, what all we need to treat. So management of PCOS, it is basically a targeted therapy approach. Whatever problem the patient comes to us, if she wants achieve pregnancy, she's having infertility, we focus on that. If she has hyperandrogenism features, we focus on that. If the adolescent girls, what comes to us mostly, we see with irregular cycles, so we have to regularize their cycles, and accordingly we have to treat the patients. Obesity, dyslipidemia, whatever the problems have, we have to jot down all the problems that this patient is having, and we have to treat all these things. So diet and lifestyle changes. It is a first-line therapy, and this is to be given to all the patients, whether she has one comorbidity or she has no comorbidity. Once you have made a diagnosis, this is for all the patients, and the rest of the therapy is a targeted approach. So today we will be talking about the insulin sensitizers, because as discussed, this PCOS is associated with insulin resistance. And metformin has been used since ages, since 1994. It is used for reducing insulin resistance. Because if you see, the insulin, it binds to this insulin receptor and forms a complex. Now this will stimulate the messenger phosphatidylinositol 3 kinase, which will activate GLUT4, and then it will lead to the entry of the glucose into the cell. So if the glucose does not enter into the cell, if there is some problem here, if GLUT4 does not get activated, then what will happen? The glucose will go on increasing in the body, and it will not be able to enter into the cells. When glucose will go on increasing, the insulin will go on increasing to combat it. So it will lead to hyperglycemia, it will lead to diabetes, it will lead to more hyperinsulinemia. This is all what is going to result if there is some problem at this level, that is at the messenger level or at the enzyme level. So what does metformin do? It stimulates PI3 kinase. This is the way it is helping. So insulin regulates blood glucose in 2 ways. The first is promoting glucose cell uptake by the GLUT4. And now when the glucose cell uptake has been done, one is that the glucose can be used for energy, and the second, it can be stored as glycogen. But this insulin action, it needs secondary messengers, and these secondary messengers is where our inositols play a role. So Myo-inositol promotes the glucose cell intake by the insulin, and D-Chiro, it stimulates glycogen synthesis. So insulin has 2 actions. One is mediated through Myo-inositol and one can be held by D-Chiro. D-Chiro, as it stimulates glycogen synthesis, so it will be present in high concentration in glycogen storage tissues like liver, muscles, and fat, and low in the tissue with need elevated energy levels. Because Myo-inositol, it promotes the glucose cell uptake. So it is going to give you the energy. So it will be where the tissue needs energy, that is brain, ovary, and heart. So Myo-inositol helps in both production and activation of this PI3 kinase. And as told, this PI3 kinase activation will activate GLUT4, and then only the glucose will have entry into the cells and then further transformation to glycogen. So what are these inositols? It is not something made artificially. It is commonly found in fruits, vegetables, and we all have it. But we don't know what we are having it. In the leafy vegetables also, in grapefruit, it is in the highest quantity. And in all the foods which contain seeds, beans, almonds, and walnuts, it's the highest in walnuts. So you people must be having it already in your meals. Now, enzyme epimerase, it is required to convert Myo-inositol to D-Chiro. So if you have Myo-inositol in your body, it will get converted to D-Chiro by epimerase. And this enzyme is this conversion, it is insulin dependent. So Myo-inositol, it is the most common form, and 99% of inositol in the human tissue is Myo-inositol. Only 1% get converts to D-Chiro. So only 1% is there in the human tissues in the where the glycogen storage tissues. Rest, where the energy is needed, we have myo-inositol. It enables insulin and FSH signal transduction in the ovary. So now coming to our main topic, that is ovary. Let's see what is happening in the ovary. So ovary, there is FSH signal transduction and insulin is making the glucose entry there. But now what will happen if there is insulin deficiency? I'll be telling that. So just remember this myo-inositol, it enables the insulin and FSH signal transduction in ovary. But if we see di-chiro-inositol, it is required for insulin action in the peripheral tissues for glycogen. But in the ovary, it will stimulate the testosterone production. So if di-chiro-inositol increases in our body, then this testosterone production is going to increase. And if myo-inositol, it goes down, then the ovary will not get energy. The oocytes will not get energy. So myo-inositol should always remain high and DCI should always remain low. And that is the physiological ratio which is maintained in our body. You see 99% in human body is MI and 1% is in human tissues. In different tissues, however, this is the total what I am telling you in the whole body. But if we see, it is different in different tissues according to the requirement. Where the glycogen is required, the ratio will be different. If I talk about ovary, the ratio will be different. But as a total, if I say in the human body, it is 99 and 1%. So MI-DCI ratio in different tissues is critically important. As you see in the ovary, if there's insulin and FSH signal transduction is required in ovary, so MI should be high. Whereas we do not require much testosterone production, so DCI should be low. So it is critically important and will determine how that tissue responds or does not respond to insulin. So in PCOS, there is deficiency of inositol. Now see what will happen. It has been seen that the plasma levels in PCOS subjects were found to be very low and urinary excretion was found to be very high. It was 5 times more urinary clearance of inositol in PCOS patients. So definitely deficiency was going to affect this point of PI3 kinase. The blood flow and the entry of glucose will not be there. And the regulation of insulin for these two pathways, that is glucose cell uptake and glycogen synthesis, both are going to shut down. Because MI is required for glucose cell uptake and DCI for conversion to glycogen. Now, both these actions get stopped because of insulin resistance. So, inositol deficiency will decrease the level of PI3 kinase, decrease the glucose uptake. So, it will lead to hyperglycemia because glucose is not able to enter into the cells. So, blood glucose will go on increasing and its response, insulin, will go on increasing and leading to PCOS. There is insulin resistance. 50 to 80% of the PCOS women are found to have insulin resistance, and it is the primary cause in the PCOS, whether it is obese and lean PCOS. So when insulin resistance occurs, the conversion rate is affected. So excess insulin is there. When there will be excess insulin, I told you there is an enzyme epimerase which converts MI to DCI. Now this MI will go on converting to DCI. Because of hyperglycemia, glucose is not entering into the cells. More and more insulin is produced in the body, which is leading to hyperinsulinemia. And this insulin will go on activating epimerase, and this is what is going to happen in the ovary. More and more MI will get converted into DCI. So if you see in the obese PCOS patients, the insulin resistance is very high. So epimerase activity is triggered. And in ovaries, the normal physiological ratio is 40:1, which gets disturbed. So that is the DCI paradox in the ovaries, that high insulin level increases the conversion of MI to DCI. And in the ovaries, as told, myo-inositol is helping in FSH signaling, whereas DCI is leading to testosterone production. So now FSH signaling will not be there. And what will happen? It will worsen the energy state of the oocytes, because a myo-inositol was helping in glucose uptake. So it will worsen the energy states of the oocytes, whereas the increased DCI, because of more and more conversion to MI to DCI, there will be more and more production of androgen, the testosterone, and that is why you see hyperandrogenemia. So if the inositol deficiency is corrected, what will happen? There will be glucose uptake. The oocytes are going to get the energy. There will be good oocyte formation. Testosterone level will go down, because then more MI will not get converted into DCI if we give it in a correct ratio. So now, could inositols be considered to treat PCOD? So let's see what the clinical trials have to say about it, what the studies. You will be glad to know the studies have been started since 1999. And the first study was done in US, but they used alone DCI. Now, DCI is already in excess in ovary, and that is what is troubling us. We want a particular ratio in the body and in every tissue. It is a particular ratio which is needed. If you give only DCI, it's never going to help. So that is what happened in the US. They did the trials, they didn't get success, they left it. Now this ball was cast by the Europeans, and they started doing trials. But they initially also started, they focused on only myo-inositol. So if you see these studies, after 10 years it started with only myo-inositol, and all the European studies which started. So they gave 3 months of myo-inositol and they found the difference. The plasma LH, testosterone, free testosterone, insulin, HOMA index, all were significantly reduced. That is what is biochemical. If you see clinically also, after 6 months, hirsutism and acne were reduced. You see, after then 3 months, there was 21% decrease, and there was 53% decrease in acne after 6 months. Similarly, if I see here, the same thing happened, the testosterone level also decreased, and there was statistically significant difference in the total as well as the free testosterone levels. So biochemical hyperandrogenism, clinical hyperandrogenism, dyslipidemia, LH hormone levels, everything showed a difference by only myo-inositol. So the trials continued. Then they started doing double-blind trials. Initially they did with placebo. Then when they found good results, that the patients have ovulated, there was reduction in testosterone. So all at every focus, it's focusing on the ovulatory dysfunction. It is focusing on hyperandrogenism. So also the dyslipidemia, everything is getting better. So the patients are responding. So it was a good push for us to do more and more clinical trials. Again, this was the trial, but they were on short trials, 3 months, 6 months, and they were using only placebo. Now, as I told, metformin has been used since ages. So coming to after this comparison with placebo and getting good results, clinical pregnancy rates, ovulation, then now in 2010, after 1 year of research, in 2010, they started to compare it with metformin, which is also an insulin sensitizer and has been used since ages. So they found myo-inositol to even better off metformin. It was 65% spontaneous ovulation and pregnancy was seen in 30%. So that was again a good push for us. So more and more studies were conducted. Here again, they did it in 2017. But here again, we see the subjects are very less. There were only 60 subjects. But yes, the results were definitely encouraging. In 2019, there was a meta-analysis and they also found a strong evidence of they found no difference between metformin and myo-inositol in the efficacy. But yes, they said the metformin patient had gastritis, and that was a statistically significant thing, which was not found with myo-inositol. Because if you are giving some drug from 99, we came to 2019, what was happening? Just efficacy, efficacy, efficacy. So they thought, let's do the safety profile also, comparing it with an age-old drug. And then they found that there was nothing. The patient were very comfortable. They accepted myo-inositol, but metformin, the patients were complaining of gastritis, which was unacceptable. In 2017 also, there was a meta-analysis, and they found myo-inositol was associated with significantly improved clinical pregnancy rate. Even grade 1 embryos and total amount of ovulation drugs were improved in favor of myo-inositol. Now, this is the physiological plasma ratio 40:1 of MI versus DCI. So now let's see what is the clinical evidence has to say about this combination. So this was once RCT, which was done in 2012, where they compared now MI plus DCI group with MI. And now they found that MI DCI is giving even better results than with only MI. Because initially when they gave DCI, there were poor results. So they stopped it. Then they picked up MI, they found good results. So they were continuing with MI, different doses of MI, comparing it with metformin. But then this group, they thought of including MI plus DCI, and when they compared, they got good results. So these things continued. Again, there was a combination. They did again a study in 2013, which again showed them a very good results. So the combined therapy, myo-inositol plus D-Chiro in a physiological ratio reduces the cardiovascular risk by improving the lipid profile in PCOS patients. So whether it is the metabolic, or it is ovulatory dysfunction, or it is hyperandrogenism, improvement has been seen throughout. Safety has been seen throughout. Although the one thing which happened is that we had a small number of subjects. That is the only thing which is happening. We don't have a very, very big trial on many subjects. In 2016, they enrolled 46 patients affected by PCOS and randomly assigned to two groups, one with the association of MI plus DCI and again with placebo. Again, they found good results. So now this was only one study. They thought of comparing different ratios. We have seen that MI plus DCI is giving even better results. But now what ratio? Let's try out different ratios. So this was the study which was done to show different ratios. And they found 40:1 as a perfect ratio because it matches with the physiological ratio as it's physiological. So it gave very good results. So combined treatment in physiological ratio of 40:1 is able to restore both hormonal and metabolic parameters in overweight PCOS women earlier than with myo-inositol alone. See, they have given for 3 months or 6 months. It's not that you take a pill now and you will get benefit. So you have to wait for at least 3 to 6 months to see the effect. And you have to give it in a correct ratio. Hence the rationale of 40:1. Now going to some of the studies about safety of ionositol. So in 2012, they found that it is not only safe in pregnancy, but beneficial. It reduces the chances of neural tube defects. There is improvement in gestational diabetes. So if you find metformin, we are continuing it in the pregnancy also. Suppose the patient was on metformin and she conceived. So similarly, you can continue this also. Although we don't have the trials of it in pregnancy, but yes, they have done a study and they have found it to be safe. And we have already seen that there is improvement in gestational diabetes. Side effects were very mild and mainly nausea and flatus and diarrhea. It is well-tolerated drug, safe both in obese and lean PCOS. In 2019, there was RCT comparing pregnant women with gestational diabetes who were randomized to either inositol or either placebo or no treatment. Now they have made 3 groups and they found inositol supplementation. And here if you see, it included 965 participants. It was a big study in the pregnant women to see the safety. So inositol supplementation was associated with lower rate of gestational diabetes, lower preterm deliveries, and no adverse effects. So key points are MI and DCI, that is myo-inositol and D-Chiro inositol, play a key role in insulin receptor signaling. Low levels of myo-inositol adversely affects the ovarian function and the egg quality, and elevated levels of DCI in ovary cause increased androgen production. So supplementation of 40:1 ratio of MI is to DCI improves metabolic endpoints in PCOS women. It also restores ovulation and improves fertility in PCOS patients. Now finally coming to what are the recommendations, what the guidelines have to say. Asstt 2008 quoted that myo-inositol can be evaluated as the primary method for ovulation induction in PCOS women. Then ASRM in 2012 said that myo-inositol treatment should be routinely introduced in IVF protocols. And now the recent, that is International Evidence-Based Guidelines for the Assessment and Management of Polycystic Ovarian Syndrome 2018 says that inositol in any form should currently be considered an experimental therapy in PCOS with emerging evidence on efficacy, highlighting the need for further research. Thank you.
Thank you, Dr. Kavita. That was really an excellent scientific deliberation on the use of myo-inositol in PCOS. You have rightly said it's a new drug. Of course, the guidelines still have to prove that it is one of the best drug and evidence has to prove it. But we have seen the effect of myo-inositol and DCI in the treatment of both clinical as well as biochemical hyperandrogenism. And the effect has also been seen in the obese PCOS. They increase the chances of fertility, increase the pregnancy rates, and they also reverse the hirsutism as well. But of course, as you rightly said, the other factors have also to be taken into account, like lifestyle modification, diet, exercise, and together with the drugs. Only drug will not help the PCOS patient. It's the change in the lifestyle modification, which also goes a long way in treating and regulating PCOS patients. I think it was a good scientific deliberation, and you have rightly highlighted the role of and the ratio in which the myo-inositol and DCI should be given.
Thank you.
Over to you, Dr. Deepika, for your next program. Or
yes, ma'am. Ma'am, we also have a couple of questions in the Q&A.
Okay.
So Dr. Monica is asking, what is better, myo-inositol only or combination of myo and D-Chiro?
Dr. Kavita has already told this.
Yes, yes. And then she says, even in lean PCOS?
Yeah, in both.
And then Dr. Dulal Gope asking, how long should one take myo-inositol D-Chiro inositol?
Minimum 3 months, so that you can see benefit. Can go up to 6 months also. It's nothing like that you have to limit it 6 months, 1 year. It's nothing like that. None of the limit has come till today.
Right. Dr. Yukti Bhardwaj has a question. What is the effect of MI on weight, ma'am?
Weight is actually, it has a very big confounding factor about the diet and lifestyle. So that is one thing you cannot judge. Yeah, it is said that diet and lifestyle, then it leads to 5 to 10% reduction. But if you are taking myo-inositol or combination, but along with that, if the patient is not maintaining diet and lifestyle, so that thing is actually which cannot be computed out, that how much it can be benefit. So that is why it has not been done in the studies.
Right. And then Dr. Kirti Jain, ma'am, can we use only MI and DCI for the treatment?
Yeah, definitely you can use it. But if the patient has, supposing, very high blood sugars, then you will like to add metformin also as an oral hypoglycemic. So it depends what all comorbidities your patient is having. First, you have to list all of them, and it has to be a targeted thing. What the patient, according to the problem, the treatment has to be there.
So she also says, or combo with OCPs and MI DCI?
See, it depends. If supposing the patient has much of acne, hirsutism, or she has irregular cycles, so you can use that also. You can give, supposing you are giving, it will OCPs, so it will regularize her cycles also. Plus, MI and DCI is going to relieve her also from acne and hirsutism, so you can give both. It's not, see, it is something you are taking normally in your food. So it's not that it's going to react with somebody, you can react with some other drug, or you cannot take, it's not safe somewhere. It's nothing like that. It is something which you are taking in your food. So it is a very safe thing.
There are so many, thank yous and very nice talk and all. Dr. Jayashri Joshi.
Thank you so much, everyone.
Yeah, Dr. Jayashri Joshi, Dr.
It was indeed a very excellent scientific deliberation, and everything was made very clear.
Then Dr. Dilip Kumar Datta, he's also said thanks. Dr. Bashir Hussain is from Somalia saying thank you. Meanwhile, we have Mr. Ram Kumar, our zonal sales manager, with us to address to you. 2 minutes to you.
Good evening, doctors. Thank you for the opportunity. Doctor, in obese and lean PCOS and associated this infertility, we have our Cystelia-M Myo-inositol 1.1 gram with the D-Chiro inositol 27.6 milligram with the 40:1 ratio, and L-methyl folate 1 milligram and vitamin D3 1000 international units tablet. Cystelia-M is the right combination to restore the reproductive health, and Cystelia-M is ideal choice to restore ovulation, which improves the oocyte quality, improves the ART outcomes, and reduces the hormone index and improves the spontaneous pregnancy rate also. As per ASRM and ISRA recommendations, we are having the Myo-inositol 1.1 gram and D-Chiro 27.6 milligram with the 40:1 ratio. It's a actually, as per ASRM and ISRA recommendation, we got to prescribe 2.2 milligram of Myo-inositol. It is ideal dosage. Our Cystelia-M comes with a chewable tablet with a strawberry flavor, doctor, and in PCOS with the obese and lean, and PCOS are associated with infertility and unexplained infertility also. Please prescribe our Cystelia-M, doctor. And because Cystelia-35, which is a cyclotron ester 2 milligram and ethanol estradiol 35 mg tablet. Cystelia-35 is a dependable choice for predictable result in acne, criticism, and menstrual irregularities and dysmenorrhea. The dependable Cystelia-35 is a dependable choice in normalization menstrual irregularities within 6 cycles and complete disappearance of acne and criticism after 6 cycles, and a complete abolition of dysmenorrhea in 4 to 12 cycles. Dr. Cystelia-35, it's a dependable choice for your predictable result. Thank you, doctor. Thank you, Ananda.
Thank you very much, Mr. Ram Kumar. Thank you very much for joining us today. And we would like to thank everybody